I left 20 minutes early today and I still didn't get here on time.
What?
So I left 20 minutes early today and I still didn't get here on time.
So what's the problem?
That stupid traffic. I thought that being a little early I would miss the traffic. Turns out,
It's worse.
yeah.
Yeah, you have to really time it. So, GI planning. So,
Farm fresh.
what are the areas that are in the GI? If I told you GI, what's GI? What does GI stand for, first of all?
Gastrointestinal.
Gastrointestinal. So what areas does that, what areas of treatment would we do? If you were doing GI malignancies, what would they be? Anybody? Yeah, they say non-esophagus in the chapter, so we'll ignore esophagus. We did it before. Stomach, yeah.
Your small
Anybody
intestine.
else?
Your small intestine.
Small intestine, okay.
Your large intestine.
What else? The large intestine, yeah.
Pancreas.
Pancreas.
Your liver.
Uh-huh. Kidneys.
Stomach.
No, that's not GI. What would kidneys be?
Urinary.
Urinary. So kidneys is not counted GI.
I know.
So what we'll do here is we'll go through.
Oh, it literally said, okay, I'm sorry.
Non-esophageal. It's okay. No, because remember we did esophagus when we did chest, right?
Yeah.
So just because you mentioned it, how many parts are there to the esophagus?
3.
3, okay? So where do they, it's in thirds. So what third is in the chest?
The lower.
Pardon?
Lower third.
No.
Lower two
Somebody
thirds.
said this when you're
No.
Steven every day.
In the chest.
The middle third.
Oh.
So you have what is called the upper third, or some people call it postcricoid. So it's the part that comes up to here. That's the upper third. The middle third is in the chest. The lower third, or sometimes they'll call it gastroesophageal junction, or esophageal gastric junction, gastroesophageal junction, or GE. That's the lower third. So that's the part in the abdomen. So it's saying non-esophageal treatment.
It smells like
Medical radiation technology.
It doesn't, I put a lot.
Okay, so
unless it's cream or something.
First things first.
Just a little bit.
I would say I like
She says
a little bit of food. I did put a little too
So-
much milk.
CT scan levels. So if you're scanning a patient, it's helpful to know what levels to scan. If the doctor doesn't tell you, then at least you have an idea. So, pancreas and gastric. So pancreas and stomach. Scan from above the diaphragm to below the kidneys. Does that make sense? Where is your pancreas in your stomach? Whereabouts? Your pancreas in your stomach. I guess I'm gonna have to get. This, by the way, is Cecil. Did I mention that to you? This is Cecil. This is Cecil. There's a story behind it, but that's okay. So, this is the stomach. Where's the pancreas? Anybody? This is the stomach. Where's the pancreas?
Right-hand side.
On the right-hand side, so it's actually underneath the liver, it's hiding. Okay, so let's put him over here for a minute. So you would scan basically from above the diaphragm to below the kidneys. And that would give you a reasonable amount. So for rectal and anal, you scan from about L3 to 6 centimeters below external anal marker. Now, for the anus, you would put a little marker, or the physician would actually, put a little marker on either the most inferior part of the anus or the most inferior part of the tumor, whichever is lower. Because sometimes, gross as it may sound, sometimes the tumor actually grows out of the anus. So you have to do below. So you're scanning from L3, which is this is L3 to probably down here somewhere. So L3, and usually if you say L3, it's usually the intervertebral disc down to here, unless the physician tells you otherwise. So, contrasts. Some of the departments will use contrast for CT. Some may not, but some will. So you have oral contrast, you have IV contrast. Sometimes you have rectal contrast. The most common is either IV or oral. So oral contrast, see the small bowel. What would you think that they would give oral contrast? What kind of oral contrast? I'm not sure whether that was in the book or not. Barium, thank you, barium. What does it look like? Milky.
They have flavored ones.
They have flavored ones. Last I heard there was strawberry, vanilla, banana, and I think they were coming out of chocolate and blueberry. I think they brought one out for blueberry. But anyway, so you asked to swallow that. You ask the patient to swallow it. And that basically coats whatever you're looking for. It coats the esophagus, it coats the bowel. IV contrast used to see tumor and lymph nodes. So IV contrast, what is that usually? Anybody? Anybody see it used? What is it you use then? Okay, Anisha.
You said IV contrast is what?
What is it? What type of material is it used?
I don't remember, but it's clear. It's a clear liquid.
It's clear. Yeah.
Yeah, I don't know.
Either.
Oh, that's good.
You can use non-iodine as well. So what would be the contraindication to using iodine?
Allergic.
How do you know if you're allergic to it?
I've had
You
it
don't know
before.
till you get it.
No.
So Kyle learned that he was
There's
allergic.
another way to tell, actually. Yeah, ma'am.
We at Left Flagler don't have to do the contrast
The nurses do?
MRI people come over and do it.
Okay, yeah, but still, you have to know what you're,
Yeah,
You're
that's what I'm
using,
asking.
yeah.
Are we gonna have to?
no.
Oh, okay.
So it'll either be, usually it's the nurses
Okay.
that do it.
When it's put through a port, it's the nurse.
Yeah, and sometimes you put it in through an IV here, start an IV here. So the theory is if you're allergic to IV contrast, you also probably will be allergic to shellfish.
Really?
What if you don't know if you're like,
Well, then you don't know. It's like everything else. You don't know you're allergic until somebody gives you something, right?
Kyle found
So-
out he was allergic. His butt and his feet get all rashy.
Say again, sorry, it was sneezing.
So my husband's butt and his feet got covered in rashes,
Oh,
and that's
yeah.
how he found out. It was very
Eyes,
itchy for
Nice, yeah.
weeks.
So most people, if they're allergic to shellfish, they're allergic to the IV contrast. So they're allergic to it. So what they'll use is what they call non-ionic, which means there's very little iodine in it. The only problem is it's about 3 times as expensive as the iodine
I
stuff.
wouldn't give them that.
So they'd rather not use it if at all possible. But they can give you, if you just have a mild reaction like hives, which is probably what it was, they can give you antihistamine before they start.
Yeah, that's what they do. They don't
Yeah,
give him
but
one.
if you had an anaphylactic reaction, then obviously they're not gonna use it. So barium enema may be used to help see rectal and anal tumors. So barium enemas aren't used that much anymore, but you can use it. Trouble is it's very messy because basically they're putting barium into the anal canal and into the rectum, and it comes out, so it gets kind of messy. So fiducial markers, we were talking about fiducial markers not that long ago. Give me an example. What is a fiducial marker? What is a fiducial marker? Say again?
They can be placed, they can be natural, just
it's a
markers
landmark.
that we use to help identify on imaging.
Okay, so they can be BBs that you put on the skin.
They can be calcification.
Yeah. They can be weird anatomical features, shall we say. So it says here surgical clips. So if the surgeons go in, sometimes what they'll do is they'll put little clips in to show where the tumor was that they've taken out. And these surgical clips are usually gold. So the clips, as it says here, clips should only be used for reference because the surgery alters normal anatomy. Anytime you have surgery, you destroy normal anatomy. Now I have to separate you two guys. Okay.
You're talking about barium.
Pardon?
Nothing.
Okay, so surgical clips or the BBs that you use in CT. Anything that is put inside on the skin or anatomical irregularities, shall we say, can be used as a fiducial marker. So, organs of interest, pancreas and gastric cancer. So, what organs are you looking for that may cause you to alter your dose? First thing is the liver. You're doing pancreas and gastric. As we see, the pancreas sits on one side of the abdomen, upper abdomen. The other side is the stomach, so slightly above it. Small bowel. You have to be careful with the small bowel. Duodenum? Yeah, not really. Stomach. If you're treating the pancreas, then you have to treat some of the stomach. If you're treating the stomach, probably you have to treat some of the pancreas. We're not too worried about the stomach. Why not?
Radio resistant.
Pardon?
Radio resistant.
It's very radio resistant, so you still have to be careful, but it's not too bad. So, organs of interest, rectal and anal cancer. So again, the small bowel, and how do we get, is there a way to get the small bowel out of the way? Prone, yeah. With or without a belly board. Belly board actually works better because it's hole in the middle, so the small bowel is down. But if you're prone at all, then the small bowel gets out of the way. Bladder, femoral heads, external genitalia, remaining large bowel, and iliac crests. So why are we concerned about the bones, the femoral heads, and the iliac crests? Why are we concerned about that?
Bone marrow, maybe?
Say again?
Bone marrow, maybe?
Bone marrow, yeah. Bone marrow in the long bones, right? Lots of bone marrow in the long bones. So you try and keep as much of it out of the treatment as possible. And same with the ischial crest, because you've got a lot of bone in there. So IMRT is almost always used for everything these days, but certainly for GIs. Main advantage lies in the potential reduction in normal tissue toxicity. I'll have to change that. So why can we reduce the normal tissue toxicity when using IMRT? How do we do that?
Your MLCs.
Say again?
Your MLCs.
MLCs, yeah, and what does using the MLC do?
You can contour the dose.
So you can tailor, if you like, you can tailor the dose to match whatever area you're treating. So, critical structures. The book goes into a lot more detail, but spinal cord. Says here less than 50 gray. What do we normally stop it at? 45, yeah. So liver, 2/3 of the organ, we need to be looking at less than 48 gray. Mean dose, less than 30 gray. So everybody knows what I mean by mean dose? What is the mean in math?
Average.
Pardon?
The average.
The average, yeah. So kidney, equivalent of one whole kidney is less than 20 gray. Mean dose for the whole kidney is less than 16. So we definitely do not want to go over 20 gray for the kidney. I'll be sending this to you. If patient, this stands to reason, and I'm not being facetious, but however, if a patient only has one kidney, keep 60% of the organ below 18 gray. I would say keep it below 15 gray myself, but obviously if you have a patient with only one kidney, you really don't want to treat that kidney. You have to try your best not to take that. Small bowel. So if you're treating 10% of the bowel, only 10% of the bowel, or up to 10% of the bowel, it can receive 54 gray. But the more bowel you include, the lower the dose goes. That happens with all of them. So if you're only treating a little bit of spinal cord, you could maybe get away with 50 gray. But if you're treating the normal amount of spinal cord, then you want to keep it to 45. So most people would keep spinal cord dose to under 45. So stomach, 10% may receive 54, and as you go higher in the amount that is treated, the lower the dose goes. Femoral head, maximum dose to small area, 50 gray. And iliac crest, you see the difference. So no more than 5% above 50 gray, no more than 50% above 30 gray, and no more than 90% above 10 gray. So if you're treating all of the iliac crest, if you're including all of the iliac crest, you don't want it to go above 10 gray. Which is where IMRT comes in very, very well, because you can tailor it around. So, pancreas. What does neoadjuvant mean? Neoadjuvant.
Pre-op.
Say again?
Pre-op.
Pre-op?
Yeah.
Yeah, because it says it there.
Uh-huh.
Yeah. So what does let's get that. What does adjuvant? If you're given adjuvant treatment, what does that mean? Along with or at the same time as. So neo. Before, yeah. So neoadjuvant means that you're treating something before. So it's pre-op. So pre-op chemoradiation is selected borderline resectable patients. So if a patient is on the border whether they can be surgically handled, then we may do a pre-op. Pre-op treatment usually is what is called debulking. What does debulking mean? Reducing the size, yeah. So if you have a large tumor and the surgeons want to do their thing and they say it's awful big, it would be really difficult to get all of it. So they send it over to us, we treat them, shrinks the tumor, and then they go ahead. So post-op adjuvant, notice most of them, in fact all of them, are chemo radiation, which in this case, post-op as well. It means that they're giving chemo at the same time as radiation. And I'm not talking about Monday they go for chemo and finish and then we treat them the rest of the week. We have patients, and this is usually all of the GI systems. We treat them while the chemo is running. Has anybody ever had somebody who is in chemo running? You usually have a little backpack or something in a fanny pack or something like that they have, and it's 24 hours a day. So we treat them with the chemo running. That's pure chemo radiation. We're doing it at the same time. And then it says definitive chemo radiation. or SBRT with or without chemo for unresectable T4 disease. So what is SBRT again? SBRT? Stereotactic body radiotherapy, yeah. How many fractions for stereotactic body radiotherapy?
1 to 5.
Say again?
1 to 5.
One, usually 3 to 5. One is SRS. Usually the body radiotherapy is not given one off, it's usually spread out a little bit. So, the other thing is there a problem with treating pancreas technically? If you're treating the pancreas, what would be a technical reason where you'd have to be extremely careful? What area? I'll give you a clue. Breath control. The pancreas sits up here, right? Everybody agree the pancreas sits up here somewhere? If you're breathing, the diaphragm moves, so does the pancreas, and the stomach for that matter. So you have to be careful of breathing. So breath control comes into it. Okay, immobilization. Supine, arms above the head, back walker wingboard, and or wingboard. Does that sound reasonable? The pancreas. Can you put something under the legs? Yes? Why? Why can we use it under the legs? The pancreas.
Because it's far enough up that
It's far enough
So it's not
superior
gonna-
that the pelvic tilt doesn't make any difference. So for SBRT, so we need rigid immobilization. Full body back lock and motion management or breath control. So how do we do that? What's everybody seen for breath control? Abdominal belt, okay. Anybody else seen anything else? You remember the picture I had of the poor patient that looked like he was saran wrapped in place? That would also work for, but he also had a body, an abdominal belt on as well. So doses and fractionation. So we're doing IMRT, conventional fractionation, and this is not conventional treatment, this is IMRT. So we normally would give 1.8 gray per fraction, so 180 centigrade. Everybody agree with that? Anybody not agree with that? Okay. So neoadjuvant. So we would give neoadjuvant radiotherapy, so that's pre-op, 45 to 50.4 gray. So that's 4,500 to 5040 centigrade to the CTV and boost to 56 if necessary. And then adjuvant, we would give 50.4 or 5040 to CTV. And definitive, would be 50/40 to 5400. That would be your doses. What about side effects? You're treating the pancreas, which is the upper abdomen.
Nausea.
Nausea and vomiting. Usually with this, you put N/V, especially if you're doing an abdomen. Anything else? What about diarrhea? Why diarrhea? What are you treating that may cause patient diarrhea? What would you have to treat in order to treat the pancreas properly? Stomach portion, which would make it nausea and vomiting. What would you do for, where would the diarrhea come in? So are you treating any of the bowel? Small bowel? Small bowel give you diarrhea? There's a possibility. Okay. So, what are you trying to treat? So IMRT. So 95% of the PTV should receive at least 95% of the prescribed dose. No portion of the PTV should receive less than 90% of the prescribed dose. Does that make sense to everybody? So if you're giving 5,400 to the PTV, then 95% of that area should get at least 95% of that dose. That makes sense? Yes? No? Good. Okay. So, allow dose heterogeneity to increase dose to the GTV well beyond the prescribed dose to the PTV. Heterogeneity. What is that again? Heterogeneity. As far as this thing should be. What does heterogeneity mean?
Not the same.
Not the same, or actually all different, right? Because you don't have anything the same. So all of the doses, all of the tissues that you're going through are different. So you have pancreatic tissue, you have gastric tissue, you have small bowel tissue. They're all different. And then you have the bones in between. So they're all different. So that can increase the doses to a certain extent. And the treatment planning system these days has got filters to deal with that.
So you're saying the gross tumor volume could receive over 100%?
It could, but it very rarely does, because IMRT can alter that. So, dose of fractionation, so SBRT, so we have 25 to 40 gray to the GTV over 5 fractions given every other day. So what we would do is we'd treat, for example, Monday, Wednesday, Friday, Tuesday, Thursday. That would give you 5 treatments every other day. And depending on the size of the tumor or the size of the area we're treating, depends on the dose that you're gonna give. The smaller the dose, the smaller the tumor, the higher the dose you can give. So it's a very small volume, you can maybe able to give 40 gray. If it's a larger volume, you may only be able to give 25 gray. So gastric. Post-op chemoradiation is the most typical indicator. Normally, the surgeons get gastric tumors first. Surgery is the best treatment. Because, as we said earlier, the stomach is highly radioresistant. Selected cases of pre-op chemoradiation or definitive chemoradiation. Definitive means curable. So, again, supine, hands above the head, back lock and wingboard. If you don't have a wingboard, can you still treat? That's the
Yeah.
ideal. Back lock and wingboard. If you don't have a back lock, you can still use the wingboard. If you don't have a wingboard, can you still treat using the back lock?
Yeah.
So how would it differ? Where do you have the patients put their hands? They have to have their hands up above their head, right? So where, obviously with the wingboard, you hang on to something. What if you don't have a wingboard? Sort of that way. And you have the back lock built up so that it helps the shoulders. So oral contrast to you to show small bowel, and IV contrast to show tumor and lymph nodes. Again, IMRT, adjuvant radiotherapy, 4,500 in 1.8 rate per fraction, and consider 5.4, that must be it, type, for positive margins. I don't see anyone going up to 9 gray. Ignore the 9 gray. Definitive radiotherapy, 45 in 1.8. And total dose you can look for is 54 to 59.4 gray and 1.8 fractions. So the total dose, these plus boosts, should add up to this. So that's basically 5,400 to almost 6,000 centigrade. Again, IMRT. So chemoradiation, 45 to CTV, boost CTV and pre-sacral lymph nodes for an additional 5.4. So that would be 540 centigrade in 1.8 fractions. So when you're finished with the 45, then another 500 basically onto the pre-sacral lymph nodes, an additional and 1.8. So pre-sacral lymph nodes. Where do they run along? So here's the sacrum, right? Coccyx down here, we'll ignore the coccyx for a moment. So pre-sacral lymph nodes. They're just in front of the sacrum. So you treat that in small areas, parallel opposed pair, sometimes 3 fields, PA and two laterals, to 540 centigrade. So that's usually three treatments added on to that. And then the pre-op, I've never heard of this being used, but obviously somewhere it is. So pre-op short course radiation, 25 gray in 5 fractions to the PTV. So short treatment. So 2,505, and then they send them off for surgery. So rectal, neoadjuvant treatment is the most common indication. So pre-op. How do we position these patients? There's 2 ways. What's the most common way to set rectal patients up?
Backlock.
Pardon?
Backlock.
Yeah, okay.
Do you mean like
Patient
Direction?
prone or supine?
supine?
Supine. Backlock. Hands on chest. Anything under the legs? If the back lock isn't there. Or even if the back lock is there. Do you put something underneath the legs?
I don't think so.
We put a knee wedge, but that's us.
Theoretically, you should not be putting anything underneath the legs. Okay? If the patient absolutely cannot put the legs straight, then maybe. So, the classical way to treat the rectum is patient prone. On a belly board, if you have one. And that displaces a small bowel, with or without backlock. You can actually put the backlock on the belly board, but it's not really needed. So supine with the arms across the chest if treating inguinal nodes or utilizing IMRT. Some physicians say, I don't want to treat prone because it's uncomfortable for patients. And that's why we treat them supine. So oral contrast to see the small bowel, barium enema to treat the tumor, and again, watch out for tumor displacement because the enema can actually move the tumor around. IV contrast to see the tumor and lymph nodes, anal marker to identify the anus, and it says here, consider full bladder. Some physicians wish to do full bladder with rectum. Definitive chemoradiation is most common in the management of anal cancer. Oh, for all of these actually, for pancreas, stomach, rectum, anus. What's the most common chemo used?
Zolota, oxaliplatin.
Pardon?
Zolota, oxaliplatin.
Zolota is hormone.
Okay, oxaliplatin.
5-FU.
No,
5-fluorouracil. What was the other one you said?
oxaliplatin. I know I say it wrong.
I thought it was oxyplatin,
No,
Oh.
it's like it's
Cisplatin?
No, it's oxaloplatin.
Oxalplatin, okay, yeah.
Oxalo.
yeah. The most common one is 5-fluorouracil. And the platins certainly do come in, all of the platins. Cisplatin, oxaplatin, everything. They
It's
all-
OXALIPLATI. Oxaloplatin.
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 So, definitive chemoradiation was common. So, treatment for a rare T1N0M0 lesion may include en-face electron therapy, interstitial brachytherapy, or contact therapy. Otherwise, IMRT is standard. Okay, so contact therapy. Everybody remembers the little machine that we saw last year that was about this size and it had a tube going down, and the end of it basically ended up into the rectum or the anus. Does anyone remember that photograph? Yeah? Let me see if I can find it for you. I'll throw it later.
Is it like, a vaginal cylinder?
And also, so that is for small, very small, very early cancers. T1N0M0. What does that mean? T1N0M0. And it's a very small tumor, right? T1. So, and interstitial brachytherapy. Get to brachytherapy in a little bit. En-face electrons. Does anybody remember en-face electrons? So what does en-face electrons mean? What does en-face mean? Parallel to whatever you're treating, right? So we're treating anus. How do you get an electron en-face to the anus? How would you have to position your patient?
Spread up the
There's two ways.
doggy
Pardon?
style.
One is a lithotomy position.
The what position?
Lithotomy.
Okay. That's probably heard lithotomy. That's what I heard.
Lithotomy position. So what is that? Come on,
Let's look it
ladies,
up.
you don't know.
Oh,
That's
oh,
the
like
one we
this.
talked about last week.
Yes.
You would know.
Yeah, holy
You would
jeez
know
today.
that.
Okay. Now,
I know, no, they're not ripped. They're not ripped today. Poor Steven.
well, that's one way to get them, dear.
True. That's a thick. They're not
So the
together.
problem is that not many treatment machines are fitted with stirrups. So we have to find another way to do that. So what's the other way that you might be able to do it?
With
Pardon?
a lot of tape.
Lots of tape. So how would your patient be lying?
Prone.
Prone,
With
okay.
their butt up in the air.
Butt up in the air. It's called the knee chest position.
Oh.
So basically what
That's what
happens
they call it now?
is that you would have the patient, you
I
have
gotta
a
get this on
pillow,
video.
the patient's chest is on that pillow, their head's down below the pillow,
I have it on video.
and their butts, basically their butts in the air and they're kneeling. So if you can imagine kneeling and their body's like this, there's a pillow under their chest and their head's further down. And then you have access to the anus. And again, you need tape, because you have to tape. So that's the only way
sounds
that you
kinda
can
kinky.
do
Seems like
that,
that
and
would be
it's
a-
very, sorry?
Would that be, doesn't seem like it'd be an easy position for
Imagine if you had
older.
area.
It's not an
Or-
easy position.
So do they have
Look at
an
all that tape.
alternate way to do it, or is
So
that
do
you
they-
just gotta get them
Unfortunately,
in?
the only other alternate way is to put them up in stirrups or have something that you can put the legs up. And that, with an older person,
I have it
is
in the
also
HDR room.
not the most comfortable thing in the world to do. They have tried to do patient on their side with one leg sort of up like this type thing, but it's really difficult to get into the anus that way, so, yeah, unfortunately. in
So
these
they
days-
use the tape to separate the butt cheeks?
Yeah,
Okay, got it.
you have to, one way or the other, you have to.
Tape the butt cheeks to the
We
table, no, I'm
have
kidding.
an electron right now that is positioned like that.
What, knee chest?
Yeah.
Yeah.
And she
It's,
just lays there and she's like, yeah, it's fine, you guys can just do whatever, and we have to like use so much tape.
yeah,
She has a butt.
So how old is she?
Oh, I'm
She's like
doomed.
50.
yeah.
Oh, I'm doomed.
It's very,
I know, it is what I would get.
it's very awkward. It's very inelegant. And it's very embarrassing for the patient.
She has a great attitude. She thinks it's hilarious that we have to do it. So it makes it easier for all of us.
Oh,
It's
yeah.
not as awkward.
I mean, yeah,
Imagine if you floated.
we had, I remember treating one lady like that and we had her, and she basically said, "Can everybody watch me?" And we said, no.
Yes.
But,
That's
That's
dirty.
what yoga one time.
so anyway, that's what that is. Anything other than T1, N1, N0, M0, you probably can't do that. Sometimes, however, we would do the en-face electrons for a boost. The only problem with doing it that way, and if your patient will probably realize it, it can get very uncomfortable because you're doing electrons. Where's 100% the dose on electrons?
More superficial.
Where's 100% dose on electrons?
Or what strength? 6.
Huh?
6 MeV? Or what are we doing?
Electrons. Any electrons. What's 100% dose? On the skin. So all electrons, you can have depths at 90% or 80%, which is depths. But 100% of the dose on electrons is on the skin. So if you have a patient that you're treating anal canal or anus itself, and you're treating them with electrons, it can get very uncomfortable for the patient. Especially if you're using tape every day for 3 weeks or 4 weeks or whatever. Oh, sorry. So again, okay, so immobilization and simulation, supine with hands across chest or prone on a belly board. If treating prone, consider supine for boost as it's away from the small bowel for patient comfort. The problem is that 99 times out of 100, the physician has planned the boost at the same time as he or she plans the
Probably brought it.
primary beam. But if you can do that. So you're doing the boost would be the inguinal nodes and anus. So oral contrast to see small bowels, barium enema to see tumor, IV contrast to see tumor and lymph nodes, anal marker, so you get physicians to put an anal marker on, and wire. So if you're CTing, you need some marking wire to outline where the lymph nodes are. Has anybody seen marking wire for CT? Yeah. Anybody seen it? Oh, I've got some in my office, I'll bring it in after break.
Get in there.
So, IMRT is standard. Dose fractionation, so 45 gray, 1.8 gray for fraction to CTV. Consider dose reduction after 30.6. T3, T4, or T2 lesions with residual disease after 45 should receive an additional 9 to 14.4 gray to CTV as a boost. So T2 dose, 45 to 50.4, T3, 54, T4, 54 to 59. Because T2, T3, T4, they tend to get larger. The tumors tend to get larger. So therefore, you need a little bit of a larger dose. So liver. SBRT indicators. Medically inoperable or surgically unresectable primary liver cancers. We would treat them. We don't often see them, but we would treat them. Rigid immobilization with body fix device. That's the saran wrap type stuff that you suck her ear all the air out. Breath hold or breath control, because the liver again moves with the diaphragm. Gating or abdominal compression. They're all a type of breath holds. Who's done breath holds with breast cancer? For left breast, correct? Or for both? Oh, really?
Yeah.
Mostly left.
We have a new doctor, she's fun.
Oh, okay. So normally it would just be for left breast, because obviously that's where you have a problem. So it's either breath holds, ABC breathing coordinator, abdominal compression, or gating. What are they using?
We use a DIVH, Vision RT,
Okay,
and that's what we're
explain DBIH.
using. Basically it's kind of the same thing as ABC, but they have a little, I think how to say this. So we have a little infrared system that'll come out and display on the patient's chest, and it calculates movement and stuff, and there's parameters for it, where that exact skin is. So we'll have to take imaging with them free breathing, which is just regular breathing, then we'll have them hold their breath, and we'll take a reference photo with that infrared down to make sure with the breath in, they have a little marker above their head that moves with the line, and it'll move up to the green line, that means their parameters are on. They have to hold their breath there, and it's a very trying and aggravating process, and most of the patients can't do it very well. And well, she's had 4 or 5 patients do it. We've had one do it successfully, completely. 2 of them, she's actually had to stop doing it because the patients can't do it.
Yeah.
And her whole imaging process for that is just absolute bonkers. But
The problem is you have to be very selective in your patients with that stuff. So some patients just cannot. When you think about it, I mean, if you have a patient who doesn't have good lungs at best of times, and you're trying to.
We have a badass patient who can hold her breath forever, but I think Molly, her first setup was like 2 hours. It took like 2 hours.
Just gonna do ports and stuff.
Yeah, I mean
Yeah.
there were like a ton of issues, but like just after the 2 hours, it was hard, but she was still able to like
Yeah,
do it. It was
that's the patients
Insane.
you love, because
yeah.
they will try, but not, if you get, that would be the odd person out. Most of the patients you have difficulty with.
Yeah.
I think that's it. That's the last one. So, that was basically a condensed version of chapter 7. And I'm just gonna
You
show
want me to
you,
run them
see if
for
we can
you?
make this thing work.
Make them worse.
Greg.
No. I'll kill myself and get divorced before that happens. Just a nice try. I'm gonna make you sign divorce papers and then I'll get myself.
Oh, I do upside down, I guess.
Oh, this is exciting.
Yeah,
Need a manicure.
This reminds me of.
so this is a treatment for resected pancreatic head cancer. What page is that? That's page 119. So you can see here, oops, sorry, these are just different views. So, sorry, here, you can see the, let me do it this way. Ah. This is the spine, but you see it's fairly far away from the core. This is the core. So you can see that this is the lateral view, this is the other view here, and yet the other view. So you have axial view, which is the one view that you normally would have on CT. This is a sagittal view, which is that one, and then this is the coronal view. So green is the CTV, excuse me. The PTV is blue. So this is the blue here. And the so you can see that most of the PTV and the CTV is outside of even the spinal canal or spinal column. This is actually a good little toy. I'd like to have seen this later. Oh, there you go. Oh. Is that fun? Sorry. Just a new toy. So this is 50, 40 centigrade. And the blue is 30 gray. And then there's another one, which is page 117. Which is, again, the head of the pancreas. So this is axial, this is sagittal, and this is coronal. So green is CTV and PTV is blue. So anything inside of this is the PTV. The green is the CTV. D is this is to CT. So that's just, I was going to put these on slides, but it's actually easier to do them here. That's good. Okay, let me just take that there for a minute. So let's go through the next chapter. Oh, let me show you something here. Goodness sake, there we go. So this is a dose volume histogram. So GTV is here. So you'll notice that GTV and PTV are a straight line, then they just go down, okay? So this is 6,000. So if you go up, if you're looking for the volume, so half of whatever volume it happens to be is getting, so half of the GTV is getting 56 or 5,700. Same with the PTV. So if we look at the heart, all of the heart is getting less than 1,000. If you go up to a third of the heart, then it's getting maybe a couple of hundred. Spinal cord. So this is the spinal cord here. So you go up to 50% of the spinal cord is getting 500 centigrade. The esophagus, 50% of the esophagus is getting maybe 1,200. That's how to read a DVH or dose volume histogram. So let's, so genitourinary. So what is genitourinary? What areas are included in genitourinary or GU? Kidneys, yeah. Ureters, bladder, prostate. Yeah, you're reading it off the book? Yeah, okay. So just, I think we're gonna stop here for a break, so 20 minutes. So on our clock, we're an hour fast, so
'Cause he is only gonna be like
25
that for a
to.
year.
Yeah.
Beam radiotherapy is recommended. CT simulation with at least 3mm axial slice acquisition. What does that mean? Anybody know? Who's been in CT?
Me.
So, do you know what thickness of slice to use?
There's different ones.
It's different for each.
Yeah, it depends on what the doctor.
It depends on the doctor, okay. So it doesn't depend on the part of the body that's being CT. Maybe.
Yeah, I think that there's certain things. And
Anyone
like,
else been in CT? Do you know how much? Usually it's 3mm unless you're doing an SRS or some other kind of very small area. with an SRS, they usually do 1 millimeter. But that's only for about this much. So you get so many slices if you just did 1 millimeter that you wouldn't be able to cope with it in planning. Yes, ma'am?
Why do they say at least 3 millimeters? So it could be bigger? It says
It could be, yeah, depending on,
at least 3 millimeters axial.
yeah. So basically, most people use 3 millimeters. That's the usual standard. But if you're doing a whole abdomen, for example, they may use 4 millimeters or 5 millimeters, but normally it's 3 millimeters. But if you're doing a full abdomen, you're using 2 or 3 millimeters, you can have hundreds of slices. And really, they don't need that many slices. And again, it depends on what they're doing. And in some cases, for head and neck, for example, they may use 3 millimeters from there to here, and then 2 millimeters or 1 millimeter for the area that we're going to be treating, and then 3 millimeters further down. So you'd have 3 millimeter, 1 millimeter, 3 millimeters. So it depends on what they're treating.
And that's given to you by the doctor, or is that something that we would have to come up
There's
with?
usually there's a protocol. There's usually a protocol listed CT, and it's normally a sort of physician request. So the protocol for Dr. Smith, for example, could be for all head and necks, we do 3 millimeters, 1 millimeter, 3 millimeters. For Dr. Brown, 3 millimeters all the way down. So it depends on the physician, depends on the area you're CTing.
For all of our SPRTs, we use 1.5.
Yeah.
That's for our business slides.
Yeah. So yeah, I mean, SRSs or SBRTs, you would use small fields because it is only a small area. So you'd use small 1 or 1.5 or 2 slices. And that, of course, can mount up with the number of slices you have for the dosimetrist, because remember, the dosimetrist, every slice, they have to locate all of the organs at risk and contour them on every single slice. So if you're given 250 slices, you can see how it can be time consuming for dosimetrists.
Do you have software that does that, or
Huh?
is there software that does that?
Not really, no. It usually has to be done by hand. Because every patient's different, every organ is different, so you really can't. There's stuff to help them, but most of it's done by hand.
So how long does that take them to do something like that?
Well, if they're not disturbed, a couple hours. If they are disturbed, it could be a couple of days. And it depends on how much the physician does. Some physicians will contour their own OARs, but otherwise they do the PTV and that would be it. The symmetrist would do the rest. Okay. So patient position, okay, let's do that. So image guidance. So IGRT options include cone beam, CT, ultrasound or implanted fiducials. Hip prosthesis may limit the use of CBCT due to artifacts. So normal anatomy. Routinely identified bowel, rectum, bladder, prostate, penile bulb. So all of these, if you just do bowel, rectum, bladder, prostate, penile, penis, you're contouring a lot of stuff. So This is just general principles, as it were. So seminal vesicles as needed, femoral head or neck if needed, lymph nodes, common iliac nodes, internal iliac, external iliac, presacral nodes, obturator nodes, testes as needed, penis as needed. So let me show you these. Get this, see if I can do this without. Okay, there we go. No, wait. I have to remember to do this backwards. Go. As far as it goes. Oh, there we go. So examples of ports used for four-field box technique to treat pelvic lymph nodes. So this is lateral AP projection and lateral projection. So these would be all of the areas that you would be treating. So this is pelvic nodes. So all of these are different nodes. So the yellow here, so the yellow here, and there's an orange one here, and the blue here, and then there's a red one right here. So orange is here, orange is here. This is the red, yellow, green, blue. So all of these are nodes. And this is just a field. So lateral field, here's the sacrum. So we're treating, here's the presacral nodes. It's the ones I was talking about. So presacral nodes here. And then you have other nodes, inguinal nodes up here. So this area is being treated. This area is being treated. All of this area is being treated. And the same on this one. So you can see these nodes are outside of the treatment area. Okay. Treatment planning. EBRT. Everybody knows what EBRT is, right? What is EBRT?
External beam radiation therapy.
Yeah. Just check. Okay. With intensity modulated radiation therapy, IMRT with daily IGRT is preferred, a minimum 3D conformal radiotherapy. Nobody uses that much anymore. So we're using most of them. So, radiotherapy can be used in particular cases such as prostate and select penile and urethral cases. 3D conformal. So beam energies, photon energies, 6 to 10 are typical, especially if IMRT is used. Higher energy beams can be used in testicular cancer for the posterior anterior beams, for penile and urethral cancer to achieve better dose homogeneity with treatment planning. So, we'll start with prostate. Intact prostate alone or to include pelvic lymph nodes, EBRT may be combined with radiotherapy for high-risk patients. Post-prostatectomy in the adjuvant or salvage setting to include the prostate bed plus or minus pelvic lymph nodes. So what does that mean? Post-prostatectomy in adjuvant or salvage setting. What does that mean? So post-prostatectomy is post-op, right? In the adjuvant or salvage setting. So adjuvant is treatment posterior to, or after surgery, post-surgical treatment. What does salvage mean?
Never heard that.
Salvage setting. So what would you think it, okay, so you never heard about it. So what would you think it might mean then?
Similar to adjuvants, it's a context clue.
Not really.
Trying to keep what you can.
Pardon?
Trying to keep what you can.
Yeah, basically it means that the surgery hasn't gone as well as it should have done, and they've left some of the tumor behind. So you're doing what they call salvage radiotherapy. You're treating what's left. So think about it as, remember when we have positive margins. We treat when there's positive margins. So this is basically treating what's left after the surgeon's finished. So it's salvage because they've left some there. It could be that it was too difficult, it was wrapped around nerves or something like that, and they just couldn't get it out. Or perhaps the surgeon just screwed up and didn't do a very good job. That's what they mean by salvage. So basically you're treating post-op. So to include the prostate bed, which means the prostate has been removed, at least most of it has, and you're treating prostate bed, which is where the prostate was, plus or minus pelvic lymph nodes. So if it's spread, you treat the pelvic lymph nodes. If you're sure that it hasn't spread, you don't have to treat the pelvic lymph nodes. What's the difference in size of the field if you haven't got any nodes? What kind of size, if you're just treating prostate bed, what kind of size are you treating, roughly? Something like an 8x8 field, or an 8x10 field, small, just enough to cover the prostate, depending on, of course, on the size of the prostate. But you're just covering enough of what's left from the botched or surgery, or the fact that they just couldn't get enough out of it. Or they may have decided that they don't want surgery after all, so they're treating the whole prostate. It's only a matter of about an 8x10 field. But if you're treating the nodes, then you may be treating the whole pelvis. So prior to simulation, 3 gold fiducial markers can optionally be placed transperineally. Transperineally. How do you do that? You stick an applicator in. That's usually done in surgery. A hydrogel rectal spacer can also be inserted transperineally at the time of fiducial marker placement in order to provide a temporary barrier to reduce the dose to the rectum. Has anybody seen one of those? A hydrogel rectal spacer.
Spacer?
Huh?
Spacer?
Spacer, yeah.
Yes, I've seen a bunch of them.
They have patients with space wars.
Yeah, spacer.
but they're called space ores.
Well, that's probably the brand name for them, yeah, same thing. Yeah. So the spacer is reabsorbed within 6 months of placement and can significantly reduce rectal dose. So patient preparation. How's the patient positioned? Patient is what? Supine, prone, on his
Supine.
side, what? Supine. What else is there? Backlock? No backlock?
Backlock.
Backlock, okay. Hands where? Hands on chest, okay. So patient preparation, maintaining a comfortably full bladder and empty rectum can reduce those to normal tissues, normal organs at risk. Bladder, bowel, rectum. Excessive rectal distension may be associated with worse outcomes due to geographic miss. Enema suppository and/or rectal tube to relieve gas distension is considered. So, immobilization, backlock. So CT scan, it says mid-abdomen to mid-femur. So basically, umbilicus to mid-femur. That's what you want to use, because you want to, especially if you're doing IMRT and you may have couch kicks or you may have something weird that the dosimetrist wants to do, you need a little more anatomy. So it says CT should include L4 to L5 intravertebral disc, levels superiorly to below the lesser trochanter inferiorly, and contrast. So L, was it 3 to 4? 4 to 5? 4 to 5. So you want to include, so it says mid-abdomen. So mid-abdomen would make it about here, right? So here's your 4-5 interface. So you want to include that, so you want to scan from further up, so that you're definitely going to include this. And then your lesser trochanter is where? Here. So you want to include that, so it's saying it's saying mid-femur, so if you come down here, you're definitely including this. Okay, where are we? IV contrast is not typically required, though this may be considered in select cases where nodal anatomy may need more precise definition. Retrograde urethrogram. What the heck is that? Retrograde urethrogram. Let's see what it says. 10 mil urethral contrast with penile clamp may be used to delineate the urethra and penile bulb. So what are they doing? They're putting a catheter in through the penis, putting some contrast in, putting a penile clamp on so nothing comes out. And it gives contrast to the urethra. And then oral contrast may help delineate the small bowel, though not generally required. And why would we do MRI fusion? Everyone remembers what fusion is. Why would we do MRI fusion? What would the MRI show us that the CT wouldn't?
Or soft tissue differentiation.
Yeah, yeah. So you can see a lot more soft tissue on the MRI than you can on the CT. So if you fuse them both, then you get the best of both worlds. So definition of the GTV. GTV prostate cancer generally includes the entire prostate gland, which can be best delineated by MRI. Clinically positive lymph nodes seen on planning CT or an MRI should be included as nodal GTV. And then the CTV, entire prostate plus or minus seminal vesicles, plus or minus lymph nodes, depending on the risk group. Low risk prostate cancer CTV include entire prostate only. Intermediate risk, prostate plus proximal 1 centimeter of the bilateral seminal vesicles. And high risk is CTV, prostate plus proximal 2 centimeters of the bilateral seminal vesicles. Consider entire seminal vesicles if prostate involved, plus or minus pelvic lymph nodes up to L5S1 or higher if pelvic lymph nodes are clinically involved. So in other words, all of the involved nodes. Yeah. Go back, go down, go down, go down, go down. Here we go. Okay. So here is your sagittal projection of target volumes and organ at risk, placement of a rectal spacer, a CT simulation scan fused with presumably MRI for tissue delineation. So there is the sacrum here, rectum is here, rectal spacer is here, penile bulb, prostate, and bladder, and seminal vesicles up here. So normally, if you're treating the prostate with nodes, you would normally treat seminal vesicles. If you're treating the prostate alone, you may or may not treat seminal vesicles. Okay. So anterior and posterior feet. So anterior L5 to S1 or higher, depending on the desired coverage of the common iliac lymph nodes. Inferior, the bottom of the ischial tuberosity, or 1.5 centimeters below the apex of the urethrogram. Lateral, 1 to 1.5 centimeters lateral to the pelvic rim. And block regions including the small bowel, femoral head, and external genitalia. And then you've got lateral field borders, 1 centimeter anterior to the symphysis pubis, posterior S3, S4, and block regions including the small bowel, femoral head, and external genitalia. And we're going back. This is a fun thing. I'm glad I found this. Or I'm glad that the IT people found it for me. Okay, so here is the prostate, the bladder, the femoral, the seminal vesicles, and the rectal spacer. Here's the bladder and the pelvic lymph nodes with the rectum here. This is the rectum here too. Let me see if I can, oh, look at that, it's not fun. Okay, here's the pelvic lymph nodes. So these are all the nodes, this one and this one you would have to treat if your prostate cancer has spread. And again, here is your fiducial markers. Everybody treated someone with fiducial markers? Okay. So how many of them are there usually? 2, 3, 4?
I usually see
There's usually 3.
two. Really?
There's usually 3. Sometimes it's difficult to get,
Well, we match two.
yeah, you match 2. Sometimes if you match 2 and the other one's slightly off, they'll say, okay, match the 2. If you can get 3 of them on, that's wonderful. But, so, just a quick question. If you have someone with prostate patient with fiducial markers, and the protocol is in your department that you match the fiducial markers, is that all you do? Or do you match the fiducial markers and then check the soft tissue? Check the prostate?
Check.
Okay, so you match your fiducial markers first, and then you check the prostate. What happens if you don't agree?
Then you go and you
You do it with which?
You go with the tissue and the prostate, because who cares about, I mean, that's just to help you.
Yeah.
Like, they're not.
Yeah.
You're not
So you
treating
go-
the markers.
You go with the prostate.
Yeah.
Now you'll get some physicians who will say, go with the fiducial marker. If it's off, if your prostate doesn't coincide with your fiducial markers, they may say go with the fiducials, which I totally disagree with, but
Oh, yeah.
it's their, you know, the buck stops with them, unfortunately. So anyway, yeah, you should go with the tissue. Okay, the modern treatment IMRT provides superior sparing of normal tissues for lymph node coverage, see section, target volumes, and organs of interest definition, which we just did. So lymph node CTVs, 7mm expansion around vessels in the internal, external iliac obturators and presacral regions. So we are including the pelvic nodes there. So standard fractionation. Just out of interest, when you're treating patients, are you noting what the doses are? What the total dose is for your patients? If you're treating a prostate, what's the dose that they're giving you? What's the dose they're giving the patient? Do you know that? Pardon? Okay, so you should, at this stage of the game, guys, you should be able to tell me what doses are being given for every single site that you treat.
You're talking about the total dose?
And the daily dose as well. So it's normally around 180, right? Centigrade, or 200, depending on what you're treating. But you should be able to know what the fractionation is, which means that you should know the total dose, the number of fractions, and the daily dose. Right? Okay. So, standard fractionation includes 75.6 to 79.2 gray. in 1.8 or 2 gray per fraction. If treating pelvic nodes, prescribe initial 45 to 50.4, and then you can reduce the dose and give a boost area to that. So yeah, your standard fractionation is close to 80. Depending on Molly, you were saying 82?
I haven't seen it myself personally, but we were discussing it with one of the therapists. And he said that he's had a few different ones that might have been boosted included.
Yeah. So yeah, depending on the normal dose, I believe at the moment is about 72 to 78. That's the normal dose these days, but you know, the smaller the area you're treating, the higher the dose. And remember with IMRT, your margin of error is very small. It can be 1 to 2 millimeters. So with that small of an area, you can go very high. Prostate always was high, but you can go even higher with IMRT. So moderately hypofractionated schedules. What are hypofractionated? What is hypofractionated? Anybody? Hypofractionated?
Less than normal.
Less than normal, very much less than normal usually. So hypofractionated means that they're either giving fewer than 5 days a week treatment, or they're giving a very short treatment, or both. So here it says moderately hypofractionated schedule includes 70 gray in 2.5 gray per fraction, or 70.2 gray in 2.7 gray per fraction, or 60 gray in 3 gray per fraction. So it's a higher daily dose, but it's a shorter overall time. So if you look at the 60 gray, that's 6,000 centigrade, and you've got 300 a day. How quickly do we do that? What's your overall treatment time?
10 days.
Pardon?
10 days?
10 days?
Isn't it?
60 gray, 300 a day. 6,300 a day. Anybody? I don't think small
8.
is 10 fractions. 10 fractions would be 3,000. 20.
Twice that.
So it's a lot faster than 8 or 9 weeks, right? So when you're treating elective pelvic nodes, the prostate and proximal seminal vesicles prescribed 70 gray in 2.5 gray per fraction, or 50.4 gray and 1.8 gray per fraction. So extreme fractionation would be, wow, 40 gray and 8 gray per fraction every other day. That would be almost, it says SBRT. So 40 gray, that's 5 days, isn't it? 40 gray and 8 gray per fraction. That's fine. Yeah, that's SBRT. That's definitely SBRT, yeah. So we have this for patients with low volume metastatic castrate sensitive prostate cancer. RT to the prostate may be indicated based on the systemic therapy in advancing or metastatic prostate cancer. Evaluation of drug efficacy, which is called STAMP-E. Randomized trial. Doses include 55 gray in 20 fractions once daily, or 36 gray in 6 fractions weekly. So 36 gray in 6 fractions once a week, or 55 in 20 fractions daily. So that would be 4 weeks. And the other one would be 6 weeks, but only treated once a week. So, IMRT technique are standard. Lateral fields are to be avoided if hip prosthesis is used. So we normally would do arcs, right? 2 or 3 arcs, right? So how do we avoid the hip prosthesis? Have you ever seen a hip prosthesis treated? Prostate, pardon?
We don't avoid them, we just line up to bony instead of the prostate. Because we have a guy right now that's under treatment, and he has double,
Hip prosthesis, yeah.
so we just line up to his bony and then we kind of can see the prostate a little bit, not really, so we just go to bony and that's what the doctor.
And you're doing arcs?
Mhm.
I had that, when I was at UPI, we had a prostate patient like that. He had one hip prosthesis, but it was an organ. Just wanted to see.
Yeah, but how do you treat them? Is there any different way to treat them? You're doing arcs, right? Is there any way to miss the prostheses?
Something that you just turn off as it goes past that area.
Yes. Oh, thank you. Thank you. Yeah, basically.
I've seen it not for I don't remember what we were doing it for, we were trying to skip something, it wasn't a prosthetic hip though. And I've seen it do that.
Yeah, basically what you do is you do the arc and then it's planned so that at a certain point in your arc, which would be somewhere down here, the machine would continue, but the radiation would switch off. And then it would start again after it was away from the prosthesis. And that's how you do it. It's according to one of my dosimetrist friends, it's a bitch to plan, but it works. So anyway, so there you go. So critical structures. So we would do those constraints, fractionated RT. So we've already gone through this moderate hypofractionation. We'll just skip that for a minute. Okay. So here's actually an interesting page 144. There's a little table there. So this is contouring guidelines for the dosimetrist. So rectum, begin contouring superior at the level of the rectal sigmoid junction. Continue contouring inferiorly to the level of the anal verge. Or B, alternatively, start at the anal verge and continue and contour superiorly for a maximum length of 15 centimeters or until boundary of rectal sigmoid junction. So you can see if you do 3 millimeter slices in CT, and you're gonna do a maximum length of 15 centimeters, you have, just to do the rectum, how many slices do you have? So 3 millimeter slices, and you're doing a maximum of 15 centimeters.
How many millimeters you're gonna send?
No, well, exactly. So how many slices are you gonna have to contour on?
A lot.
A lot, okay.
Yeah.
So 15 times 50, 30, basically. So it's a lot. And you have to do these one at a time. So you may get one slice and you do the little part of the rectum that you can see, and then you do a little part of the bladder, and then the bowel, and then the femoral heads, and then the penile bulb, and then the seminal vesicles, and then else the doc wants to do. Meanwhile, he is doing the PTV, and maybe if you're lucky, the CTV, but the dosimetrist has to do the rest. So the dose, volume, and criteria. So if you have 30% of the rectum down at the bottom, okay, up at the top. So if you have 25% of the rectum per protocol, less than 70 gray. Acceptable variation, less than 75 gray. Nobody is going to give 70 gray to the rectum. But that is 25% of the rectum. Here's the bladder. 90% of the bladder, less than 35 gray. Acceptable variation, less than 40 gray. So 40, if you're doing a prostate, and it's saying here, this is a hypofractionation one, 70 gray in 28 fractions. So you're giving 70 gray to the prostate. You also want to give 50% of the rectum 60 gray, less than 60 gray, hopefully, yes. This bears looking at. Here's another one for my little friend. Okay. Yes, I have a new toy. Oh. Get it. Oh, there we are. I just have to get used to doing this is all. There we go. So this is the contours. So the yellow inside that yellow is 70 gray. Purple, which is here, is 56 gray. And the blue is 35 gray. And then if we go over here, so CTV is green, PTV is blue, so this is 5 millimeter PTV margin and daily image guidance. So post-op prostate bed contours and isodose line distribution using volumetric modulated arc therapy with 5 millimeter margin, PTV, and daily image. So green is the CTV, blue is the PTV on sagittal and axial planning images. Okay. Doses. Doses of approximately 64 to 70 gray in 1.8 and 2 gray fractions are used post-op. Distinction in prescribed dose can be made between adjuvant and salvage. There's your difference between adjuvant and salvage. So adjuvant is absence of detectable disease, and salvage is presence of detectable disease, as follows. So 64 to 66 gray for adjuvant, 66 to 70 gray for salvage, and 45 to 50.4 to pelvic lymph nodes is indicated. So dose volume objectives for radiotherapy to the prostate bed after radical prostatectomy as per RTOG and NRG trials, both clinical trials. So rectum less than 25% receiving greater than 65. Wow. Less than 45% receiving greater than 40. And less than 25% receiving 64.8 to 70.2. And the bladder is less than 40% receiving 65 and less than 60% receiving greater than 40. So prostate SBRT has increasing utilization as definitive treatment for intact prostate cancer. Generally, potential candidates for SBRT include patients with low and intermediate risk prostate cancer, gland size less than 100 mils, without baseline obstructive urinary symptoms. Let's see what 8.5 says. Okay. Oh, here's your fancy rectal balloon, guys. Sorry, next page. So patient prep. MRI fusion may allow more accurate delineation of the CTV when available. If MRI unavailable, may use retrograde urethrogram to help define apex and penile bulb. Fiducial markers, gold seed or calypso transponders could be placed for localization. A full bladder minimizes the dose to small bowel and bladder. Body molds recommended for mobilization. absorbable hydrogel spacer may be placed. Alternatively, a rectal balloon inflated with 60 or 80 mils of air may be considered to provide prostate mobilization and clear prostate rectum interface. What do you guys use for, to fill your balloon? Do you use air? How much? Is it same or is it till the full?
60.
Say again?
60 cc.
60 cc? Okay, that's good. So 60 cc is the same as 60 ml. Right.
Yeah,
Approximately, yeah, approximately. Some people would argue that fact, but approximately it's the same thing. Okay, localization. So here is. Here again, I'm gonna screw this up again, but let's see. This with it. Too much problems here. I'm going this way and that. There. So again, here's your rectal balloon. Again, your ISDOS, your CTV is green, your PTV is blue. So blue is 29 gray, yellow, green is 36.25, and red or purple is 32.62. Up here, get this up a bit here. Yeah, man, get over it. Why is, oh, this is too. There. So, here again is your dose volume histogram. So again, you have CTV and PTV are both here. So the rectum is black and or dark brown. So if somebody came to you and said, okay, Mr. Smith's PTV or DVH, dose volume histogram, how much dose is 50% of his rectum getting? Can you see from there? So here's 50%. Basically all you do is go along here and you get to this line and you go down. So in this particular case, his rectum is getting 750. So what about the right femur, which is blue? 50% here is about maybe 85%, 8,500, 850. If you asked about 20%, you would get 1,200. Urethra at 50% is getting about 700. You get how this is working? Make sense? That's the problem with actually using this thing. I can't see everybody. Okay. So prostate brachytherapy. So this is low dose rate. Definitive treatment as monotherapy for primary, low, and intermediate risk patients. Monotherapy. That means we're using it on its own, right? So we're using low dose rate. Would that be permanent seeds or would that be temporary if it was low dose rate? Permanent. Everybody agree with that? Permanent? Okay. High dose rate or HDR would be, they would come in, have treatment, come out again, and come back a week later or 2 weeks later. And combination treatment with external beams. So what we can do, and what sometimes is done, is that we give the patient something like 5,000 centigrade externally, and then they go for seeds to give the rest of the dose. And it can either be permanent or temporary. Determining which patients are good candidates for prostate brachytherapy is highly dependent on basically where it's being done and who's doing it, and relies on the skill and expertise of the treating physician. Some of the physicians will do it all the time, others may do it once in a while. You want to have someone who does it a lot if you're going to do it at all. So what happens is that they do what is called a volume study, using either ultrasound or CT. And that basically tells you how big the prostate is. And then from that, they can plan. Evaluate pubic arch, interference with CT or ultrasound. If prostate volume is too large or interference of the pubic arch exists, hormone therapy can be initiated 2 to 3 months prior to implantation for gland size reduction, if needed before prostate brachytherapy, to attempt to reduce the likelihood of obstructive urinary complications. Preoperatively, patients are instructed to avoid aspirin or anticoagulants for at least 5 days. Why?
You don't want someone on a blood thinner when they're getting surgery.
Well, it's not really surgery, is it?
You're getting cut open-ish.
Somewhat, yeah. They're sticking things into you, yeah, so you can bleed, yeah. Yeah, exactly. It's to stop blood loss as much as possible. An enema is given on the morning of procedure. That's basically to clean you out, as it were. Perioperative IV antibiotics should be given. Gentamicin coverage can be added if a patient has a metal implant or a pacemaker. And either general or spinal anesthesia is used. So we either put them out or they use spinal. Those people who have had children will know what spinal means. Right. Okay, so patient position is, okay. So patient is placed in an extended dorsal lithotomy position. Yes, they stick their feet up in stirrups. Patient position is critical to minimize pubic bone interference due to seed placement. Pelvis must be flexed so the pubic arch is elevated, and genitalia are taped anteriorly out of the field. The perineal skin is shaved, and the rectum is irrigated with saline and a rectal catheter. Perineum is prepped with betadine. 10 millimeters of ultrasound jelly is injected into the rectum. Sounds evil, doesn't it, guys? An ultrasound probe is placed within the rectum using an ultrasound stabilization device. which helps ensure reproducibility, the time of initial ultrasound image acquisition, and then the ultrasound stabilization device should not be readjusted after the treatment plan has been finalized, as this could lead to a geometric miss. So what do we use? iodine 125, yttrium iodine 125, half-life 60 days, palladium 109, half-life is 17 days, or cesium 131, half-life is 9.7 days. These are commonly used for low-dose prostate brachytherapy. Transrectal ultrasound images of the prostate are captured at 5 millimeter intervals and exported to a treatment planning system. So the plan is done. And then they are implanted. And there's a beautiful picture of an ultrasound, which is so pre-treatment DVH, pre-treatment DVH, which is at the top here, prostate, bladder, and rectum. And then we have all of these little dots are the seeds. All circulating around the rectum. So note that 150% isodose line spares the periurethral tissue centrally, right here. So here is the red, the purple, I'm sorry, is 144 gray. So that would be 150, it would be 216 gray, 200% would be 288 gray. So we'll go with 100%, so 144 gray. Does that sound awful much? What's your normal dose for prostate? We'll say 78 to 80 for external beam. Here, you're getting 144 at 100%. 144 gray. That's an awful lot of dose, isn't it? Why can we do that without doing damage to the patient? Or irreparable damage to the patient, should I say. Like all brachytherapy, you're treating a very, very small volume. You're basically treating just, remember, these are gentlemen with prostates intact. So how big is the prostate? A normal, quote, there's no such thing as a normal prostate, but what kind of size is a normal prostate? It's a walnut. It's about that size. You know the walnuts with all the nut inside of the shell? It's about that size. It gets bigger as the gentleman gets older, but they're not usually much bigger than this. So you're giving that amount of dose to that amount of tissue. So it really, and it only goes to that little bit of tissue. and a little bit surrounding it. So it actually works very well.
I still don't understand anything over 100% dose. So like 150% and 200% of the prescribed dose?
Yeah,
So,
so 144 is 100% prescribed dose.
but the rest, the other areas are getting 150% and 200%.
That's correct.
Why would you want to do, if you're prescribing somebody a certain amount, you actually
Why are
want
you
it?
doubling?
Yeah,
Why are you
why don't
doubling
you
it?
just say, I want the dose to be higher instead of, I don't understand the.
Well,
150.
this is a calculation, this isn't actually being given.
Okay,
So you're giving the 100%, they just want to know what the 200% or 150% is.
theoretically, if we did
Yeah.
this is how it would turn out, doesn't
Exactly.
mean it was accepted.
No.
Okay, that I can live with. 'Cause I'm really confused on
Yeah,
why.
no,
Okay, then.
okay. So it looks as if we're just gonna be stuck with doing the prostate. So, has anybody managed to see a prostate, brachytherapy done yet? Do you know if any of your sites do them? I'm sure Gainesville does them somewhere.
Gainesville did them right across the hall, and I'm kicking myself for not trying to scoot over there, but from what I'm hearing, it's hard to find any place that's doing it in the same building.
You usually do them in a separate building.
They're right across from the next floor, but I've asked about it twice. And they're like, oh, just say something about it before you leave. And I'm like, okay, that's exactly what I was told at UTCI too for everything else.
That's what I was told about going to the hospital too.
Yeah,
Just get it in the semester. It's like, okay, well, it's in the semester. Oh, okay, I've got time for it. Okay, thanks.
yeah. Have you spoken to Philip about it?
Not Philip about it. I mean, I mentioned at the very beginning. but
Right.
That's also what he said at the very beginning. So we'll get back to me later after you've got some time in.
Some information, yeah, right, yeah. So Baptist must do them,
I've seen a bunch of GYNs, but
not prostate. I wanna just ask, see if they do them. They may not do them, but, at least if you see gynae ones, that's fine, or breast. Who's seen breast, Savvy, right? Yeah. Anybody else seen Savvy, or was it Savvy or was it Monocyte? Savvy? Okay. What's the difference between Savvy and Monocyte? Do you know?
Well, I know what savvy is.
Yeah, so, okay, tell me what Savvy is, ladies.
It's like a thing that looks like a whisk, but it has little holes for like catheters to be attached to the HDR. They,
So how many seeds can you put in?
is there 10 around there? Yeah, 10 big, we have one. They don't
It
use
depends
all
on
of
how
them.
big your
Yeah, they don't
breast
use all
is.
of them,
Right.
so,
Yeah, so it's more than one.
yes.
Yeah. The difference between a Savvy and a Monocyte is that the Savvy can use more than one. The Monocyte only uses one. So that's, and of course, a different manufacturer, so. But that's,
Yeah, Orange Park does a lot of those.
huh?
Orange Park does a lot of those,
That's good.
unfortunately.
Well, that's good. No, that's
They
good.
made it.
So let's get back to prostate, talk about,
Oh, no.
yeah. So here's the dose and fractionation. Monotherapy prescription dose, which is, fractionation for prostate seeds only, is, 145 gray for I-125 and palladium 103 and 115 gray for cesium-131. When administered as a combination therapy for 45 gray pelvis external beam, the prescription dose is 110 gray for I-125 and 90 to 100 gray for palladium 103 and 75 to 85 gray for cesium-131. So on its own, you have something like 145, and then for combination, you have 45 external and basically approximately 75 to 100 gray. So it's 145 approximately. So I think we won't go into the bladder because we don't have time to do that, if you pardon the phrase. So any questions about prostate? Or GU, for that matter? This is the more common treatments that we do, obviously, is bladder, or prostate and bladder. Has anybody seen anything other than prostate as far as GU goes? No? Nobody's seen bladder?
I've seen that.
You've seen bladder? Oh yeah, that's the, yeah.
The one we treated full.
Yeah, you want to treat it full. Did you ever find out why?
Yeah, because he was only treating a portion of the bladder, so he
Ah.
wanted a bigger.
That makes sense, yeah. So, Asia, that picture you sent me, very pretty by the way, thank you. What was, I meant to ask you before, and then I was looking at it later on, and I'm thinking, what was his diagnosis, do you remember?
I have no clue.